About PICM, we are familiar with that, and about 10 to 20% of the patients suffered from PICM after 2 or 3 years of RV pacing. And the PSM is characterized by the reduction in LV ejection fraction in patients with a very high pacing burden and no other identifiable cause of heart failure. And the PSM is also associated with an increased risk of atrial fibrillation, hospitalization due to the heart failure, and the cardiac myopathy. And the conduction system pacing, including the HBP and LBBP, had demonstrated a substantial improvement in LV ejection fraction and heart failure symptoms in PICM. About the definition of the PSM, the current definition of PSM including 3 aspects. The first is the reduction in ejection fraction by at least 10%, with a baseline ejection fraction exceeding 50%. The RV pacing burden is more than 20%, and the absence of any other definitive cause of heart failure. But what we say is just like the top of the iceberg. Many people suffered from the heart failure triggered by the RV pacing, although the LV ejection fraction level doesn't reduce obviously, such as the hospitalization due to the heart failure, such as the heart failure symptom, and such as the atrial fibrillation. So we should pay more attention on the PICM, especially we have the better therapy of conduction system pacing on the PICM. So according to the understanding of the CSP, so I think the application of CSP in PICM should include 2 aspects. The first is that how to avoid PICM, how to choose the suitable patient when we do the pacemaker implantation, how to choose the RV pacing, how to choose the CSP pacing. And the second aspect is that how to treat the PSM, how to choose the upgrade mortality, including the BIVP, including the HBP or LBP, how to choose. So the first aspect of the PSM is the how to determine the predictor of the PSM. As we all know, the pacing burden and the years after device implantation is very important to decide the PSM. But many studies had many data to show more factors were associated with the predictor of the PSM, such as the native QRS duration and the paced QRS duration and the advanced age and the myocardial score and RV pacing burden and reduce the baseline LV ejection fraction. So I think the last one, reduce the baseline LV ejection fraction, is very important to make clear the predictor, to make clear the high risk of the PICM. And this is the data is from our center. We also found another predictor of PSM, that's atrial fibrillation. In our study, we found the atrial fibrillation is an important predictor of PSM. From the data volume is more than 700. And if the patient has 5 predictors, including atrial fibrillation, the wide QRS duration, the RV pacing percentage more than 90, or baseline LV ejection fraction is less than 52%, and the baseline LV EDD is more than 49. So if all of the factors were found in one patient, the risk is maybe raised about 18 times compared to other patients. So very important for the atrial fibrillation. And especially when the atrial fibrillation has such characters, including the old, the very aged, the enlarged LVDDD, the decreased LV ejection fraction, and the wide pacemaker course duration. So if such a patient has some character in the atrial fibrillation, we should pay much attention. Maybe the CSP is a better choice for such patient. And as to how to treat the patient suffered from the PICM, how to choose the upgrade mortality. We choose the traditional BIVP or choose the CSP. Let me say some data. The data including about nearly all the study published recently. We found that if the patient accepts the BIVP upgrading, the LV ejection fraction improved, but the data, but the improvement was later limited, about from 25 to 36%, and so on. But if the patient accepts the his-bundle pacing upgrade, we can find that nearly all the patients get about nearly normal LV ejection fraction. It's around the 50%. So it's very important. And if the patient accepts the LBB pacing, we nearly get the same result as the data from the HBP pacing upgrade. So LBBP and HBP is nearly has the same result. But how to compare the result of HBP pacing and the BIVP pacing upgrade? We can get some result from this study. This study demonstrated that the baseline character has nearly no difference. But after upgrade, it found that the HBP upgrade has more satisfied outcomes, including the course duration and LV ejection fraction. And as to the CSP upgrade and the BIVP upgrade comparison, we can get some message from our study. In our study, we enrolled about 50 patients, and about 37 patients accept the CSP upgrade, and only 11 patients accept the BIVP pacing upgrade. And from our data, we found that after the CSP upgrade, the course duration and the LV ejection fraction and the LV DDD improved obviously. But the improvement between his bond pacing and LBP pacing was similar, has no obvious difference. And as to how to choose the CSP upgrade modality, which is better, HBP pacing or LBP pacing, which is better, we can get some message from Dr. Ye. If the patient is suffered from the infranodal atrial ventricular block, maybe LBP pacing is a better choice. So the outcome was demonstrated here, and the LBP pacing improved LV ejection fraction and LV ESV. But how to compare the HBP and LBBP pacing in the patient without infranodal atrial ventricular pacing? We do some study. The data is also from our center. In our center, we found that if the patient accepts the HBP upgrading and LBP upgrading, the result was similar, was not obviously different, including the QRS duration, the cardiac function, the LV size and LV size, and the LV ejection fraction. So maybe we can get the result that from the current data, we didn't find a difference in HBP pacing and LBP pacing in patients with the PICM. So the guidelines gave me some recommendation about the upgrade of PICM. From the guidelines, we can find that the CRT upgrade has more data, more proofs to be recommended as the class 2 level. And from the HR's guidelines, we can find that if the patient suffered from PICM, the conduction system pacing upgrade has the same recommendation level compared to the CRT upgrade. So from here, we get more data and more proof to do the CSP upgrading in patients with the PICM. Now we can see two cases. The first case is a very old female patient. He suffered from neck fraction and was found the ECG was the 3rd-degree atrial ventricular block. So he was referred to accept the leadless pacemaker implantation. This is ECG before the operation, and he accepted the leadless pacemaker implantation. But we also can find that the AV synchrony is not very good. And about 1 month after the leadless implantation, he came back to the hospital for the heart failure. The local doctor called me, Dr. Dong, would you like to help him? He's very serious now. His system blood pressure is less than 90, and need the injection drug to improve the blood pressure, and his heart failure is very serious now. So the ECG show me that the AV synchrony is not good, and the ratio of the AV synchrony is only about 60% for the leadless pacemaker. So the patient echo demonstrates that the original LV ejection fraction is 60%, but after 1 month leadless pacing, the LV ejection fraction is only 32%. And so this patient, we think he suffered from PICM in very short time. So this patient accepted the CSP upgrade, and Next day, we do the blood pressure test. We found that the systolic blood pressure raised to more than 120. So the patient go back to the island, to his hometown, and when we call her to go back to our hospital to do the follow-up, he refused us. He tell us he's very well now, and everything is okay. Another case is that a patient is also a female patient, accepted the pacemaker implantation for the atrial ventricular block. The original echo demonstrates that the airway ejaculation is a little reduced, and the airway EDD is a little enlarged. This is the ECG after the pacemaker implantation, with the airway lead located in the septum of the airway. But from this ECG, we can find that the current duration is not very wide, and the axis of the ECG is not very abnormal. But unfortunately, the patient suffered from the PICM, and 3 years after the RA pacing, the ECG was only 39%, and about 5 years after RA pacing, the ejection fraction is only 27%. So this patient accepted the upgrading or conduction system pacing. But unfortunately, we found that this patient is infranodal atrial ventricular block. This is A. We had no any relationship. So now, how to choose the upgrading modality is HBP, still HBP or the LBBP. So I think most doctors will choose the LBB pacing, but I think maybe we can try HBP pacing at the distal end of the his bundle. So we try how to do the distal HBP. We push the lead a little until the potential of the his bundle disappeared. And now that means we go beyond the block site. So now here we do the pacing. We found the ECG morphology is as same as his intrinsic QRS morphology. So I think this is we can catch the distal end of the HBP. And this patient, the airway ejection fraction increased to higher than 50% about 6 months after follow-up. So to summary, PICM is not rare in the real world. And in the future, I think the CSP would be recommended in PICM patients with the high risk and the CSP upgrading is superior to BYP upgrading in PSM from the current data. Absolutely. And of course, the RCT was necessary to prove our guess and prove the data. Oh, thank you.